Kia ora, Gillian, and kia ora koutou, nei rā te mihi atu ki a koutou. Ai, e tū tēnei tētahi uri no muri whenua, no te raroa, ara me ngā iwi katoa muri whenua. Kia ora everyone, thank you for the introduction, Gillian, and for opening Jane with a karakia. I'm going to hook straight into it. Some of you may know me as Gillian said, I work for the Canterbury District Health Board as the Executive Director of Māori and Pacific Health. Hopefully I'm sharing the screen with you. Can someone give me a thumbs up if you can see it? Yep, you can see my presentation there. Cool, yep, that's great. So I am going to speak to you today about the underlying theme for this particular series of sessions, which is who's in the room. Ko wai I roto I te ruma, who's in the room. And I'm going to start in what may seem like an odd way, but I'm going to go back in time a little bit to some events that some of you may remember. So yeah, kia ora, that's me. Let's go back in time. I was actually at high school at this time in 1981. I was in the fifth form. Don't ask me what year that is. I think it's about a year 11, sitting school certificate. But I wasn't concentrating much on school certificate when this was going on. The 1981 Springbok tour. And what an interesting time in our country's history that was. There was protest all around the country. There were people dropping tacks and on rugby fields, police with long batons and protesters in helmets. And much of it seems quite surreal today when we think about it, that it was such a violent confrontation between New Zealand citizens and our police force. But for some it was about rugby, for many it was about apartheid, about New Zealand's position in the world, about whether or not we would tacitly support racism and separate development in another part of the world with a country that we'd had long-standing relationships with. But an interesting time, 1981. Fast forward to a little bit closer at the time, the Foreshore and Seabed Act of 2004. And we had unprecedented scenes outside the seat of Parliament. I was in Wellington this week, lovely walking around the grounds of Government House and the Beehive. It certainly didn't look like this. Literally thousands of people who had marched on Parliament protesting the passing of the Foreshore and Seabed Act of 2004. Very, very controversial time, which later got overturned by a later government. Then a few years later, we had what's become known as the Urewera police raids in 2007. And again, you know, those of us in Christchurch were used to a year ago of armed police walking around our city. It seemed very, very surreal. But the town of Ruatoki was certainly not used to armed police walking around with loaded semi-automatic weapons. It's not a sight we like to see in New Zealand. And that occurred in the Urewera in 2007, and some interesting things popped out of that. It cost the New Zealand taxpayer more than $6 million in legal costs. The surveillance costs and the police costs were more than $8 million. The police seized 4 weapons, 4 guns, 230 rounds of ammunition, and they arrested 18 people. And those raids were a culmination of more than a year of surveillance that uncovered, in the view of the police at the time, so-called training camps. And they actually believed that there were Māori in the Urewera who were training to be terrorists in New Zealand. On the 8th of November, the Solicitor General actually declined to press charges under the Terrorism Suppression Act, and the Supreme Court later found that much of the evidence gathered by police had been done so unlawfully. And after all of that money and all of that time, of the 17, there were 17 people charged, 13 were thrown out. Those charges were dropped. Only 4 proceeded to trial, and they were tried on weapons, possession of weapons, and criminal organisation offences. So it's an awful lot of work for actually, in the grander scheme of things, quite minor weapons and assembly offences. Then in recent memory, we have the Census 2018. 1 in 7 New Zealanders failed to complete the 2018 census, and it led to the resignation of New Zealand's chief statistician. And it took more than a year, almost 18 months, before we saw any data come out of that 2018 census. It was an abject failure in statistics gathering in New Zealand and in census in New Zealand. So an interesting set of events: the Springbok Tour, the Foreshore and Seabed Act, the Urewera police raids, Census 2018. Why am I talking to you about these things? Because they do represent abject failures in New Zealand's history. So I'm asking the question, how did the people concerned in those events, and there are a number of other events I could have picked on, but I picked on those ones, how did they get it so wrong? And my perspective is that the answer is similar in each of these cases. Firstly, they had the wrong people in the room. The rugby union had the wrong people in the room when they were discussing whether or not New Zealand should be playing South Africa in rugby. The cabinet, Helen Clark's cabinet in both 2004 and 2007, were talking to the wrong people. The police had no one to moderate their intelligence thinking. They seriously believed there were people in training camps training to be terrorists in the Urewera. Had they asked a couple of Tūhoe people or a couple of Māori from around the country, they would have found out that they were imagining that. There was no one moderating the thinking in the room. Essentially, it was like-minded people who were making the decisions, and what we commonly know as groupthink. And we've probably all been in situations like that. There were no alternative perspectives authentically raised in the room. You know, when Stats New Zealand sat down in 2014 or 15 and said, yeah, we think it's time for an online census, they needed some black hatters in the room. They needed some people to say, well, hang on a second, have you thought about the rural populations of New Zealand that don't have extensive internet coverage? Have you thought about our vulnerable populations in New Zealand, Māori, Pacifica, new migrants, who actually don't want to and don't know how or aren't prepared to engage in an online census? The answer to that question is they didn't ask those questions. Those questions weren't raised authentically. And I guess broadly speaking, why I'm speaking to you this afternoon is there were no Māori in the room. If you had Māori in the room, the right Māori in the room, many of those questions would have been debated authentically and different answers would have come up. You could argue, but wasn't there Māori representation at the table? Because in lots of our situations, you know, that cabinet of 2004 when the Foreshore and Seabed Act was passed had Māori cabinet members. They had Māori in the caucus, as they did in 2007 when they signed off the police raids, and there were Māori in the police force. There were Māori in Statistics New Zealand, not many, but you could argue that they were there in the room. Now, I don't know for certain, I wasn't in all of those situations, so I've said there probably they were. However, it goes to that model which we see often in health and right across the government sector is this Māori representation model. They had Māori representatives there who could say what they wanted to say and put their case. However, my advice is be wary of the Māori representation model because it has consistently failed to deliver equity or an adequate Māori voice. I was involved in the Waitangi Tribunal hearing on health and disability services outcomes in 2018, stage 1 of that. And they looked specifically at primary care, and right throughout the 20 years of the New Zealand Public Health and Disability Act, or the almost 20 years at the time, there's been Māori representation. There are Māori members on DHBs and Māori represented in various places in the system, but that model has still failed to deliver equity. So it seems intuitively like a good idea to have a Māori representative, but in fact, it seems not to work very well. Now, why? The short answer to that is democracy doesn't work very well for the minority. It's all very well to say that the Canterbury DHB has 2 Māori board members, but they're 2 of 11. You know, in an egalitarian and democratic society, those are pretty tough odds. So I'm asking the question in this presentation, do we, the royal we, all of us that work in health and look at equity and inequity, do we understand the principle from the treaty, from Te Tiriti of tino rangatiratanga? Do we know what that means? You know, when I showed those pictures earlier on of the protests for the Foreshore and Seabed Act, there were tino rangatiratanga flags all over the place. Māori understand tino rangatiratanga, but do we as a health system understand that? Do we understand what partnership means in an authentic and meaningful way? So I would phrase it in Te Reo Māori as kaia wai te mana. Who holds the mana? Who has tino rangatiratanga in your service, in your DHB, in your PHO, in your general practice, in your screening program, whatever it may be, who has tino rangatiratanga? Having an authentic partnership with Māori must confront this very thorny issue of tino rangatiratanga, of mana. I prefer the word mana. I think scholars, Māori scholars who look back at Te Tiriti o Waitangi would say that the Reverend Henry Williams used the term tino rangatiratanga as a kind of an interim between the word that Māori would favour, which is mana, but they mean similar sorts of things in this context. Māori would say kaia wai te mana. Who holds the mana? If we're going somewhere, who's deciding what's going to happen? That is to say, who has the power to make decisions? And if you think back to those examples I gave, to the Springbok tour, to the Foreshore and Seabed Act, to the Uruwera police raids, I think it can come down pretty quickly to who had the decision-making power, who knew what was going to happen, and regardless of if there were Māori in the room who had dissenting views, and we know now that for the Foreshore and Seabed Act, Tariana Turia had a dissenting view, but her view was ignored. She was not listened to. She crossed the floor. She left the party. She later formed her own party, and she was later given a title for that, Dame Tariana Turia, and well deserved in my view, but she had a dissenting view, and that view was not listened to. So there were Māori representatives there, but she did not have tino rangatiratanga, the ability to make the decision. So we call it a partnership, but actually it wasn't, because someone else had the mana. So it goes to this question, who's in the room? I think that's a really valuable question that we all need to ask. Who's in the room? Who's moderating the thinking? How can we ensure we get authentic debate so that we don't end up in groupthink and design the same old like we've always done? But I think a more important question is who's making the decisions while those voices are in the room. So let's look at another situation that's occurring right now as we speak. In the next few weeks, perhaps a couple of months, we're going to hear announcements from the government about the Health and Disability System Review. The final report came out while we were all in lockdown in June last year, and some cut and paste snapshots from the executive summary of that review. The fact that Māori health outcomes are significantly worse than those for other New Zealanders represents a failure of the health and disability system and does not reflect Te Tiriti commitments. Quote unquote out of the report, the review proposes to create an independent Māori health authority, and hasn't that generated some interesting discussion amongst my peers, Māori health general managers, amongst my colleagues in DHBs and in PHOs and the Ministry of Health as well. It would be expected, this Māori Health Authority would be expected to monitor and report on the performance of the health and disability system as it impacts on Māori. I thought there was someone already doing that. I thought actually we were all charged with monitoring the performance of the health and disability system as it impacts on Māori. So we're recreating in a different role something that ought to have already been done, and in fact should have been done by the Ministry of Health as well as DHBs. However, let's create another organisation to do that. The authority would also identify issues which need to be addressed and develop and test solutions. Again, I thought we were already doing that. I thought that's what the role of the ministry and DHBs was to do, but that's what the review said we ought to do. You'll forgive my facetiousness around that because it seems like same old, same old. However, interestingly enough, buried on page 173 of that report is an alternative view. And I've highlighted alternative here because that alternative view was actually supported by 4 of the 7 panel members. So the majority of the panel members supported the alternative view. It seems interesting that the majority considered the alternative, and the entire Māori expert advisory group. So we had a Māori expert advisory group. We commissioned those Māori voices to tell us what their expert opinions were. They gave us their expert opinions, and it was ignored. It wasn't put in the executive summary. It was buried on page 173. So hence my cynical view about this Māori representation model. Even if they're in the room, if there's no tino rangatiratanga, it's actually a token box exercise. So let's look at this Māori Health Authority that the review panel has proposed. The alternative view, buried almost 200 pages into the report. It envisages a potentially transformational future where the Māori Health Authority has the role to commission health services. So it's an authority which actually has authority to determine who gets to deliver services, to fund services, as well as enabling for Māori using an Indigenous-driven model with a proposed system to achieve equity. So Māori can determine their solutions and how that will work. Because Māori have said this for a long, long time, but we've never had the money to do it. Just imagine for a moment, if Māori is 16% of the population, if we took 16% or even 10% or 5% of vote health and gave it to a Māori Health Authority, how different would our health services look? I was looking at a dashboard last week at cervical screening and noted that in the last decade, not a single DHB has ever hit the target for cervical screening of Māori women. So in 10 years, we have funded, I don't know how many millions of dollars into that service, and it's failed for at least a decade, and we've continued to fund it. Interesting how our system does that. Now, I can tell you, if Māori looked at it, we'd stop that and we'd do something different. So I don't know what it would be, but we would look at it in quite a different light. So a Māori Health Authority that holds mana, that has tino rangatiratanga and has decision-making authority is a very, very different authority to one that just monitors and asks people to change things because it's not working so well. Now, I don't know what that will look like. Minister Little and Stephen McKernan, it's with the Department of Prime Minister and Cabinet to determine what that looks like. I'm a 55-year-old Māori male, and I've watched my entire adult life recommendations come out of the Waitangi Tribunal, out of the Ministry of Education, the Ministry of Health, recommending a whole range of things, and almost never are they implemented. So I may be a bit cynical and suspect that the minority view of that review panel might get its way. Andrew Little has been saying different things, but I have to wait and see what pans out there. I can tell you, every Māori I've spoken to who's read that report says the alternative view is what ought to be followed. That Māori need mana, they need tino rangatiratanga, the ability to make the decisions, to commission for services. So anyway, ko wai I roto I te ruma. Who's in the room? That's why I'm talking today. There must always be Māori voices in the room. Despite what I've said about the Māori representation model, there must always be Māori voices in the room. You need the Hector Matthews, the Ramon Pinks, the Linda Smiths, the Shelley Campbells, the Tariana Tudis, all of those people. Those voices need to be in the room. For partnership to be authentic, Māori must have tino rangatiratanga. Now, I'm not so naive to say that magically we're going to wave a wand and Māori are going to get tino rangatiratanga over everything, but I'm laying a stake in the ground that for partnership to be authentic, Māori have to have tino rangatiratanga. If they don't, anything less is actually just token. And the evidence shows that when Māori don't have tino rangatiratanga, the system fails Māori because we haven't got equity in a whole range of government services, not just health around the country. It fails our system and it does not address equity adequately. So being in the room without the authority to make decisions is not partnership. To use a simple example, if you look at a marriage, for example, a marriage where one person holds all the money and all the power is not a partnership. It's a dictatorship. A partnership, a marriage, is where everything is shared and everyone, the two parties in that partnership have the authority, have the tino rangatiratanga, have the decision-making authority. And when they disagree, they have to sit down and sort it out until they can agree. That's what tino rangatiratanga is. That's what partnership actually is. And so often, that's not what happens. We have Māori in the room and we ask them questions and say, kia ora, Hector, tell me your opinion. I tell them my opinion, and then it's ignored. Not always, but it's a really important thing to factor in about who's in the room is important, but actually who has tino rangatiratanga is more important. Quality and health outcomes for Māori are inseparable from mana Māori, tino rangatiratanga, the ability to make decisions about ourselves. Nothing about us without us. And to quote the late, great Dr. Ranginui Walker, ka whawhai tonu mātou. This is what our continuous struggle, our struggle without end, has been about from the day the treaty was signed back on the 6th of February in 1840. The endless struggle is about tino rangatiratanga, is about mana, our ability to decide for ourselves what will happen to us. So who's in the room? What can you actually do? I'm not going to just throw my toys out of the cot and say, well, you know, if you don't give me tino rangatiratanga, I'm going to walk away and say, bugger you, bugger it, you know, play your own game. So there are some things we can think about. As I said before, there must always be Māori voices in the room. But all of us who are involved in health, we need to know our population data. We need to know that 10% of the population in Canterbury is Māori. At Te Tairāwhiti, it's 49%, almost 50%. We need to know that a third of our population, Māori population, is under the age of 15. So we need to know how many people ought to be presenting at our services. We should know the age demographic of our population, not just the individuals. Too often I hear people say, I just treat who comes through the door. And that is simply an excuse not to deal with the fact that our services, our access to our services and the quality that we provide for our population isn't up to speed. Because if we're not seeing them come through the door, we need to change what we're doing. So we need to understand in really good detail our population data, what the inequities are, how they've come about, and what we can do to change those inequities. If we don't do that, if we don't know that, we can't possibly strive towards equity. Access to and quality of healthcare are the determinants of health that we in the health system can impact on. We can't impact on employment much, except if we employ more Māori. We can't impact on income, education, housing. All those sorts of things are not in our direct purview, but access to healthcare, changing who comes through the door, changing who we let through the door, the quality of healthcare, ensuring that Māori get the quality of healthcare that is at least the same as everyone else, and we know that it isn't. Those are things that we can change, we can directly impact on. So we have to understand that, and we have to own that as people as professionals who work in healthcare. Understand the existing inequities in your services, in your DHB, in your PHO, wherever it may be. If you don't understand those and how they came about, then you can't change them. Use evidence and data to understand why inequities exist. We know that those who have less income and less employment have poorer health outcomes. We also know that Māori proportionately have less income and less employment, poorer quality of housing. We know those things, so we know statistically that impacts on access to health and quality of health outcomes. So what are we doing about that at our service level? Be prepared to use different approaches to prioritise inequitable populations. If we know that Māori have less access to surgical services, then we need to change that. If we know that Māori present with ischemic heart disease a decade before everyone else, then we need to make sure that our decision-making algorithms get Māori into services and into surgery and into medications and into rehabilitation a decade before everyone else. At the moment, we tend to have a one-size-fits-all. If I turn up to the hospital with certain symptoms, I'm a 55-year-old Māori male, more often than not, I'll be sent home. If I was a 65-year-old Pākehā male, I'd get admitted and get access to services. We have to change those sorts of decision-making algorithms because they fail. They fail Māori and they fail equity. So we have to be prepared to take different risks to change inequity. And we also have to be prepared for the flack that will come from middle-class Pākehā in New Zealand when that occurs. When you say we're going to immunise Māori for COVID before Pākehā because they have a higher risk, you're going to get flack from middle-class Pākehā New Zealanders. We have to be prepared to take that on the shoulders because we are doing it because the data says it's the right thing to do and it addresses inequality. So it takes courage to do the right thing. One size fits all, the equality approach invariably fails vulnerable populations. Decreasing or even eliminating discretion in decision-making supports equity. Now, what I mean by that is every time, if you speak to Māori, whenever we come into a system, whether it be the health system, the education system, the justice system, whenever someone has discretion, Māori get burned. We know when we look at data that if I get pulled over by a cop, chances are I'm going to get fined, ticketed, arrested, charged. If my Pākehā wife gets pulled over, chances are she's not. That's what the data shows. If you give the cop discretion, Māori come out worse. If you give the doctor discretion in their decision making, Māori come out worse. We know that. If you give the pharmacist discretion, Māori come out worse. I'm not throwing these people under the bus. That's what the evidence shows us. Every time someone gets discretion, privileged, well-educated people get advantaged in the system. So we need to find systems, decision-making systems, which actually take discretion away from people and say, if it's a Māori that turns up and he's 55 and he has these symptoms, they get admitted. They get access to meds, they get access to surgery, they get access to services. Always have Māori voices in the room. We can't avoid that. I'm not a huge fan of the Māori representation model. It's the only thing we've got at the moment. Tino rangatiratanga is more important. But regardless, we must always have Māori voices in the room. And you notice I've said plural because too often I've been in the room and I've been the only Māori voice in the room. And it's really, really hard. It's a real burden. You feel like the weight of the entire Māori population is on your shoulders. And it's not a pleasant place to be. And invariably you get ignored anyway. So have multiple voices as much as you can. Engage early, not late, and have multiple voices in the room. And give them tino rangatiratanga if that is possible. Don't assume that it's not. Work hard. So tino rangatiratanga, I've taken a quote out of a wonderful book by Hine Moa Elder, a psychiatrist from Te Raroa, my own iwi, so I can proudly say she's one of us. And I thought this was a lovely quote that she had. Tino rangatiratanga te aroha ki te tika. Tino rangatiratanga is absolute self-determination. And it's about doing the right thing in the right way for ourselves as Māori and for others. Are there any questions?